VNAA Blueprint for Excellence, Reducing Pressure Injuries Module Tour, presented by the Visiting Nurse Associations of America. I would now like to turn the presentation over to Liza to introduce the call.
Good morning, everyone. This is Liza Greenberg. I'm Senior Consultant for Quality with VNAA, and it's been my pleasure to work with a work group to develop a new module for the VNAA Blueprint for Excellence. And we're here today to walk through the new module and put it in some context about why it's important to home health and hospice organizations. And we'll also hear from some of your peers in the home health and hospice industry talking about some of the strategies they've used to reduce pressure injury and to treat them according to evidence. So it's my pleasure to introduce our presenters. We'll have Danielle Parati, who's Vice President of Quality and Performance Improvement with VNAA, myself doing the actual walkthrough, and two of our commentators from organizations that are members of VNAA, Brenda Fox, who's the Wound and Ostomy Care Nurse Educator for Advanced Home Care, and Lynn, who's the Director of Wound and Ostomy Care for the Visiting Nurse Association Health Group. So with that, I will turn it over to Danielle to explain why preventing pressure injuries is important, and then we'll work our way through the new module. So Danielle?
Thank you, Liza, and welcome everyone. We're so glad to have you here. So I do want to talk about why this is so important, and I'm going to kind of start from the bottom of this slide and talk about the clinical reasons. As clinicians, I think we've all had the experience of trying to work with skin injuries, and I'm hesitating a little bit here on the phraseology of pressure ulcer and injury, and I'll get to that in just a moment. But from a clinical perspective, there is a very significant body, up to 17% of home health care patients that may be experiencing pressure ulcers or injuries. The incidence is large and expected to grow as our patient population continues to age and experience more comorbidities. As a result of this, our clinicians are paying, our patients are suffering, our clinicians are paying attention to it, and our policymakers are aware of the issue of skin care as well. Pressure ulcers, particularly late-stage ulcers, has been an issue for policymakers for many years now, and is now a component of the IMPACT Act, which we'll talk about a little bit more in just a second. The home health care compare and star ratings programs are also issues that look at patient quality measures. We're not entirely sure how all of these things fit together, and I will tell you neither is CMS because I have asked them specifically, but everybody is working on it. Value issues of value-based purchasing and patient experience, all of these components are swirling around at the policy level and connecting quality with reimbursement issues. And I do have to point out that pressure ulcers or pressure injury is a point that is on everyone's mind. It's on the short list for quality measures because it is measurable, because it is something that impacts patients across the care continuum, and it is already included in hospital programs that both with the IMPACT Act as well as growing programs and the future of quality measures in healthcare, I would very much anticipate pressure ulcers and injuries to be a continuing and growing topic. Next slide, please. Within the IMPACT Act, it is already identified and coming into play now in 2017. Issues of skin integrity and changes in skin integrity is one of the areas written into the legislation that is about standardizing and harmonizing patient assessments across post-acute care settings. The measure specifically is going to be looking at new or worsened pressure ulcers, stage 2 through 4, and unstageable. So basically what's going to happen here is that as the OASIS tools get filed with CMS, any patient who's identified on discharge as having had a stage 2 or stage 2, 3, 4, or unstageable ulcer at discharge will be compared to their OASIS assessment on admission, and those that developed during the course of care or worsened during the course of care will be included in this quality measure. So With VNAA, as we were looking at what's in impact, we really wanted to be able to look at the materials that already existed in the blueprint for best practice around skincare and customize them to make sure that we were providing support to agencies around this specific measure. I do want to take a moment, next slide please, and talk about this change in terminology. So as you can see, what we've written here, as well as what is currently in the blueprint, speaks to the term pressure injury. So the National Pressure Ulcer Advisory Panel, or NPUAP, recommended new guidelines in 2016. And these guidelines recommended a change to the term injury from ulcer, because they are specifically trying to look at how the skin is injured. But last week, literally, I was at a meeting with CMS and representatives from NPUAP, as well as the Alliance of Wound Care Stakeholders, another national organization looking at wound issues. And the conversation with these groups identified that there is some pretty big controversy with the adoption of this new terminology. CMS is currently stating that they have not made any steps to change from ulcer to injury, and they wouldn't comment further. The representatives from NPUAP and the Alliance of Wound Care Stakeholders both acknowledge that there is a concern in this change because the word injury has a very significant impact on the way skin care issues would be coded according to CPT diagnosis coding, and has implications in the medical legal world around injury as something that is attributable and a cause of healthcare system failure. So at this time, the adoption of the NPUAP 2016 guidelines is basically in limbo and on hold. So although we did go forward and make this module using that term, at this point we're going to slow down and revert the term back to ulcers to remain consistent with CMS. If anyone has questions on that controversy, please feel free to email me afterwards, but I'd like to turn the program back over to Liza and the team who developed the module.
Great. Thank you very much, Danielle, and also thank you for that late-breaking news, because this is something that's just been going on at the National Quality Forum, so very exciting that you were part of that discussion. So we did develop a new module that's part of the VNAA Blueprint for Excellence, and many of you may be familiar with the blueprint. It's been in action and available to both members and non-members of VNAA probably for almost 3 years now. We started out developing modules to help organizations improve quality around the issue of home health compare. It morphed then to include very robust information around overall quality strategies to help organizations meet requirements in the 5-star rating system. And now we have developed some cross-cutting linkages and new modules around the area of the Impact Act. So whenever we develop a new module, we convene a work group that has experts from the field as well as experts from our own member organizations to help us develop the content. We take the best available evidence, and when there isn't a very specific recommendation from the evidence, we use the expert consensus of our work group members to decide what will go into the blueprint. And we do want to acknowledge that many of the issues reflect a work in progress, that we don't know the absolute right answer to something. So what we present in the blueprint is kind of a portfolio of strategies that you might adopt. So as you look through the recommendations, or what we call the best practices within the blueprint, it's up to you and your leadership within your organization to determine what would work in your organization and the best ways to sort of tool and combine and mix and match the information to drive the quality outcomes that you're looking for. So with that, we'll start working our way through, and just for those of you who want very specific information about how to access the blueprint, we've provided these links here, and as Heather mentioned, you will be getting the slides, but I'm also going to show you how to navigate to the blueprint very directly yourselves. And one last time, I want to thank the Reducing Pressure Injury Work Group It was a small group of very committed individuals who helped to guide us as to what needed to be in the module, and we really appreciate their expert input. So let's see if we can get to the blueprint. So the easiest way to get to it is just in your menu bar up here, type in VNAABlueprint.org, and that will bring you to this main page here. And from here you can navigate to any of the information that's available on the blueprint. And if you look at that index down at the bottom left-hand side, you'll see all of the content for home health and hospice organizations, and you'll find resources for many, many issues that can help you improve quality of care. We're going to start here in this middle link with the Impact Act resources, where we've mixed and matched and consolidated information that can help you to get ready for or to meet your requirements under the Impact Act. And these blue bars here are all of the Impact Act measures that are either implemented starting in January or will be implemented over the next few years. And we'll continue to develop this information going forward as we know more about the measure specifications and what are the challenging areas for home health and hospice organizations. But to get to the module, there's many ways to get to it, but we tried to make it easy. You would just click on this link here, and that takes you to our starting point in the Reducing Pressure Injuries module. And as Danielle pointed out, we will look at what CMS and the expert organizations are putting out. It may revert back to the pressure ulcer language, but since that's so new, we had created the module using the term pressure injury. So once you get to this overview page, this is kind of how all of our modules are created. Every one of them has these 4 blocks up at the top of the page where they have tools and critical interventions, references and resources, measurement and evaluation, and training. And this home page that you land on explains why it's an important issue, why a home health or hospice organization would care. Also, pretty standard on most of our modules are the training slides. So at the end, we'll open up this link, but I wanted to point out to you that it's easy to find. In our training slides, we have a summary of everything that's inside of the module. So if you only have a lunch and learn or some short amount of time to share the information with your staff or your colleagues, you download the PowerPoint and just take it from there. So let's start looking into some of the blocks of information that we've embedded in the blueprint. We'll go to measurement and evaluation, and this highlights some of the information that Danielle pointed out about why all of a sudden this focus on pressure injuries. And probably the most important one was this new Impact Act measure, the National Quality Forum's measure 60678, % of residents or patients with pressure ulcers that are new or worsened. So that will be what they call a cross-cutting measure that's measured by all providers in post-acute care. And although not immediately, eventually it may become a comparative measure. And it most certainly will become something that CMS looks at, your admission and your discharge rates, to see if you are, or those injuries are occurring during the home health episode. But it's not the first time that you all have been concerned with wound care and skin integrity, because in Home Health Compare, we also have measures related to pressure injuries, the rate of checking for them, the rate of treatments, and taking action when doctors do order something. So there are many reasons that you're being held accountable for pressure injuries, and why your organization would want to develop a program or a strategy for prevention and treatment. And on every page, we have links for additional information, and these ones down here at the bottom will take you to more information about the Impact Act, Home Health Compare, star ratings, any place where you might have accountabilities around pressure injuries. So I use the back button to get back to that main navigation page, and then I'm going to go to training programs. And we also try to provide information to help our organizations understand how you need to work with staff. This is not something that one person within an agency might need to know. It's something that an organization would need to implement consistently and reliably across all of your staff that are interacting with patients. You know, actually more than the staff interacting, it also has to do with who's doing intake, who's doing administrative issues on quality assurance, so that everyone needs to be on the same page around what you're going to be doing to get the right orders to prevent pressure injuries and then do evidence-based treatment of injuries. So we've provided here some national resources around pressure injuries. I'll refer you also, there's no link right here, but in terms of developing an overall quality management strategy, our blueprint area around 5-star strategies has a lot of information about how do you set up a comprehensive quality improvement strategy so that you have reliable results across your organization. So these are outside resources here. This is a link to the slides that I mentioned earlier that will open up at the end. And then using clinical practice guidelines to sort of establish the goals, the evidence-based goals of your program, and something like the VNAA clinical procedure manual on the nuts and bolts of getting it done. How do you actually do treatment? So there's active links to all of these additional resources. And I wanted to stop here and ask one of your colleagues from the field who has agreed to speak with us about her training program. And so, Brenda, could we ask you to talk just a little bit about Advanced Home Care's training strategy and some of the things you've done to make sure that wound care is done consistently on a high-quality basis throughout the organization?
Yes, absolutely. I'm happy to share some of the things that we're doing here at Advanced Home Care. We're a 5-state agency. We are lucky enough to have 3 WOC nurses employed with our company. We have our company divided into 3 different areas. And in each area, the WOC nurse has a class, and we have named it Wound Academy. And it's actually 2 full days that any new hire, specifically geared towards the nurses. But we also do have certain classes that are physical therapists, occupational therapists, anyone who's doing OASIS in the field, they will come to that portion of the 2-day academy. But otherwise, it's our new clinicians, RNs, LPNs that spend 2 days with us. And we have an agenda that covers everything from our philosophy regarding wound care to specifically regarding pressure ulcers, surgical wounds, lower extremity ulcers, how to do the documentation so that it is done in a proper way. And then also we go into ostomy care and negative pressure. So of all those topics, we teach it from PowerPoint presentations to hands-on to discussion. We even make them practice, even if they have home care experience, how to measure a wound. Are we measuring correctly? Are we doing it, is everybody doing it the same way, so that we get that consistency. Within that 2-day time frame, what we are finding is more and more we are having to reach out to clinicians who don't have home care experience. So we are hiring nurses that have perhaps been in a hospital setting where they didn't have to do the hands-on. So in addition to teaching the wound care itself, certainly including negative pressure, we also have to get very specific regarding staging pressure ulcers, tissue types, and all of those OASIS questions that lead to showing the good work that we're doing, documenting those outcomes that we're having. And so we've been doing the Wound Academy now for about 1.5 years, and we are seeing the fruits of our labor. We are certainly seeing less and less potentially avoidable events. In that previous to Wound Academy, so many times with a potentially avoidable event, what we actually saw was that our clinicians were staging a stage 3 as a stage 2, and then when it didn't heal within 30 days, of course, it was showing as a potentially avoidable event. So we are seeing a great improvement in that, and overall an improvement in our outcomes. We are also seeing a surprisingly improvement in our nurses staying and not leaving. We feel that this additional education is giving them the tools that they need so that they are not frustrated out in the field. So that's been a really good outcome that we've seen as well. We have had to make a few changes according to the Impact Act. One of the things that happened was that the WOC nurses were brought in and put on a different team. We have a team that's called Disease Management and Practice that we laughingly say covers everything clinical. And so now we are hand in hand with that team, and we have a more direct role, not only on just what is done in the field, but what impacts our policies and our procedures. So that's been a really good move that I think happened. We are allowed to have a hand in so many things. One of the things that surprisingly is working hand in hand with our salespeople in getting those support surfaces out to patients in a timely manner, teaching our new hires the importance of that pressure redistribution, and focusing on prevention. And I think one of the biggest impacts that we've had on our clinicians, both those that are new hires and those that have been in the field, is being able to help them understand that in today's world, and certainly where value-based purchasing is coming into play, and how important it is that we are not just simply going in, doing wound care, and moving on to the next patient, that we are providing a holistic approach that takes into account all of those important factors that are so important in wound healing, from nutrition to support surfaces, certainly prevention, and utilizing all of the great tools that are out there, certainly including modules like this that are available so that those of us that are in the field and in the war zone don't have to reinvent the wheel every time, and we do have excellent resources to go to. So I would like to thank my colleagues for allowing me to participate in this. And then the last thing I want to say is we have just recently started the WTA program, the Wound Treatment Associate Program, for those of you who are familiar with that, through the WOCN Society. We just finished our first class, and we are anticipating seeing an even better improvement in our outcomes once these nurses get back in the field.
Brenda, thank you. That was really helpful, and I think you made two incredibly important points that I want to make sure that everyone captured. One is the importance that you've placed on treating the person as a whole, not just their wound, but you know, thinking about all of the person's needs. And certainly, as we're held accountable for measures like the patient experience measures and other things around how the patient perceives their treatment episode, it's really important that we keep track of not just our clinical obligations, but the whole patient experience throughout that episode. The other thing was just how interesting it was how much your training academy had an impact on other areas within your agency. So, for example, reducing turnover, which is something that all agencies struggle with. You know, if people feel more competent and more successful in their jobs through training, it can have an impact on a lot of different areas, in addition, of course, to your quality measures. So thank you for those points, and thank you for sharing your program with us.
Absolutely, thank you.
So I'm going to continue through our tour here. We've got two other sections to go through. And one of the areas in all of the modules where there's usually a lot of critical information is this tools and critical interventions area. And there's a lot of information in the whole concept of reducing pressure injuries. And so we divided it up somewhat into three areas. Agency level interventions, so these are kind of cross-cutting things you do across your agency to set up a program that promotes quality of care around pressure injuries. Then once you're in the patient's home, what are the kinds of things you need to do around prevention? And then once a patient already has a pressure injury of some type, what do you need to do to ensure effective treatment? And I did want to mention that we're not repeating what's in the clinical practice guidelines. If you want to know very specific clinical interventions for different types of wounds and types of death, that's where you would look at your clinical practice guidelines. You know, the experts have spent many years putting together evidence-based practice recommendations, and that should certainly be an organizing point around your program. But what we tried to do is layer on how does an agency use this information in an effective wound care management program. So I would also just lastly point out that there are a number of tools linked here. We try to make it as easy as possible for you to develop standardized tools or protocols, and so we have a number of links, for example, to the Braden scale, which many of you already use, treatment algorithms, SBAR toolkits, which we'll hear about SBAR from Lynn in a couple of minutes, but different things that can help you develop a comprehensive program. So let's look at what the work group recommended around agency level interventions. And our group identified a number of barriers that basically they've tried to address as they develop effective wound care programs. So some of the barriers are burdensome or non-standardized documentation systems, understaffed for certified wound care, lack of continuity, lack of coordination, challenges interfacing with the physicians. And there's no magic bullet, but we did tease out a number of really creative solutions that our members are using to try to address some of these. And one of the key strategies around things you need to do at the agency level is having a training program. And we've already heard from Brenda their kind of comprehensive approach, but it does need to address not only the clinical elements, but things like documentation. You know, if your staff are measuring the wounds using different methodologies or different tools, you're going to have, you know, false positives saying that you worsened a pressure injury when it was really present on admission. So having that consistency through training is incredibly important. Having a systematic way, for example, to make sure that OT and PT staff are trained and are engaged in this whole pressure injury piece was something that was really important. Developing your in-house staff and having that person involved in policies across the agency, for example, not only the wound care protocols, but things like DME or formulary, and how do you make sure that everything lines up so that you're able to access all of the right supplies, tools, services that your patient will need. And again, this is all in the training section, so it's kind of training people so that there is this standardized process. Quality management plays a big piece. I'm sure all of you are doing things around audits and standardized protocols in quality, but making sure that everyone is working towards the same goal, using the same tools, for example, things like digital photography, having maybe a consult staff who can support wound care staff who are on site in homes, and figuring out how to get the right expertise at the right time. This is all kind of your quality management strategy, looking at where are the gaps. Is it in the most rural patients? Is it in patients who are transitioning from home health to hospice? So figuring out where you're having the problem and applying a quality improvement strategy to that area. And then the third area around sort of skills and tools that the agency needs to take care of is really having relationships with other entities that relate to your skin integrity program. So having relationships with wound care programs, it can obviously smooth off the handoffs between them. It can also help you work with them and them work with you on evidence-based treatment strategies. Working with physicians on SBAR communications, the situation background and the recommendations, so that you can recommend very proactively to the physicians what the evidence-based treatment should be. Having a liaison with DME so that you can get what you need in a timely way and have the right things on hand. And then streamlining the whole process so that you know, you can have these communications with outside vendors and suppliers and partners in a more efficient way. So those are some of the things that the agency can do. And we'll back up and we'll get down to the patient level here. And so some of the things around patient-related challenges are things that impact the patient's risk of a skin impairment. And cognitive changes are clearly a high-risk issue. Lack of mobility, caregiver shortages, and sometimes patients just don't want DME or other things that might reduce their risk. So again, there's no magic bullet to these things, but there are things you can do to very systematically understand the patient's risk and document it, obviously, and then develop interventions. So risk assessment and planning is one of the very clear areas that will be critical to reducing the rate of new pressure injuries. And I won't go through all of these bullet points here. You can go back, but it ranges from everything to using the Braden scale or some other standardized tool on admission, to then having a planning process that includes really multidisciplinary issues that might need to bring in nutrition consults or social services consults, but understanding the risk and developing a proactive plan to prevent either worsening or new injuries. Our group felt like sometimes an organization needs to prioritize what will happen in the home for a high-risk patient, because there are so many possible things, and moisture management, pressure redistribution, and having OT and PT involved were some of the things that they felt were really part of the top priority strategies. And then again, you'll find more details on some of these other things in the actual guidelines, but there were many recommendations about providing skin care, managing incontinence, addressing mobility, which again is that PT-OT issue and is also its own Impact Act measure. So focusing on mobility could be sort of a high value area for a lot of different reasons for home health organizations. Maintaining perfusion, offloading, addressing nutrition, and managing other risks are some of the key areas where they felt that there needed to be interventions. And sometimes when there's a lack of a caregiver issue, it could be could reflect a need to refer to other sources like home health aid services or community resources that might help the individual and family to be able to prevent skin injuries more effectively. And then lastly, we'll look at treatment interventions. And again, the guidelines will guide your very granular decisions about what barriers to use and what creams and dressings and things like that. But some of the things that our organization or our work group members felt was really important was obviously focus really hard on prevention, make sure that you don't get to this point. But once you do, make sure that you understand the evidence-based treatments for each injury stage, and that might mean developing your own policies and procedures within the organization for how you think wounds of different types and characteristics and levels of infection should be treated. It means developing protocols for interfacing with physicians to make sure that you're recommending treatments that are consistent with evidence and consistent across your organization, because when you have policies and protocols that guide your staff, then everyone's doing the same thing and working towards the same goals. There were some of our workgroup members did recognize that there are sort of monikers and tools like the DIMES and TIMES mnemonics that can help your clinicians sort of in the training process and also in the wound assessment, so thinking about how those might be used in your program. Comorbidities have a big impact, so many of your wounds are related to other things like diabetes or arterial and venous insufficiency, and we know that many of our members that have wound care programs do have protocols around these other comorbidities as well. Making sure that you have the right devices in place, controlling pain, and that's again where you have another measure that's going to be looking at the same thing. Patient experience and pain will both be impacted by how well you do on the treatment of pressure injuries. Monitoring for infection and making sure that anyone else in the home, like the aides, understands what to look for in terms of infection. Developing a collaborative care plan with the patient and their caregivers. So it's not just saying, here's your plan. It's like working with them to figure out what's feasible in terms of dressing changes or mobility shifts and things like that, so that everyone, again, kind of buys into the same plan. And then many organizations are offering internal consults on wound care by having a wound care certified specialist who can connect via HIPAA-compliant iPhone or some other methodology to kind of consult on the treatment of certain wounds. So those are the kinds of things organizations are doing to create a program that is able to manage treatment of skin injuries more effectively. And so that's kind of the body of what you'll find in our tools and critical interventions area. And I'll give you a quick walkthrough about the last area, which is references and resources, and then we'll turn it over to our next home health organization presenter. So this page is resources. It kind of captures many of the resources that were on other pages. So if you feel like there's too many clicks on those first 3 sections that I walked you through, just click right to the reducing pressure injury references and resources, and you'll find everything's kind of categorized. So treatment guidelines, these are the national organizations that have developed guidelines. Performance measurement issues, so why this matters from the CMS perspective. General strategies for quality improvement and developing programs, and then specific ones to pressure injuries. Educational tools, this is an overlap of what you saw on the training page. Risk assessment, measurement tools, patient education, and then again more about the environment. And the last thing I just want to point out is the reference page, where we did pull a number of the sort of high priority references that we looked at for this, as well as things that just might be useful to you. So this is simply a cut and paste of abstracts of articles that we thought were relevant and important to this issue. So why don't I take us back to the main page, and if I could, I'll ask Lynn Arbital, who's Director of Wound and Ostomy Care for the Visiting Nurse Association Health Group in New Jersey, to talk with us a little bit about her program and how you're trying to put the pieces together to make sure that you've got evidence-based clinical practice. So Lynn, can I turn it over to you?
Thank you, Liza. So like Liza said, my name is Lynn, and I work with the VNAA Health Group in the state of New Jersey. We're a fairly large agency. I think we're the largest in New Jersey for home and hospice care. Just to give a quick overview of how our agency is set up for providing wound care is that we have branches. Since we cover a good part of New Jersey, we have branches, local branches throughout the state. At each branch level, we do have wound care certified nurses, and we utilize these nurses as our first line of defense, as I like to call it, for our wound care consults. And then as the only board-certified WOC nurse at the agency, I oversee the program. So I really like to utilize the branch-level wound care nurses, and then they will request my assistance if they need a second opinion or some additional assistance. So how I set up our program is to have a standardized model of communication. So we use what we call the SBAR communication, the S for situation, B for background, A for assessment, and R for recommendation. And that's the format that we use for all of our different types of communication, whether it be a verbal consult, an in-home consult. We're starting to roll out photography consults, and also if the nurse is contacting us via email. So for our management of the SBAR communication, our verbal consults for wounds, we start with just the basic medical history. What are the contributing factors to the patient? Do they have diabetes? Do they have peripheral vascular disease? What is the underlying medical history? Then I'll ask them, what is the specific wound history? What is the history of the wound? Is it a stasis ulcer? What type of treatments have been tried? And what has worked and what has not worked? I will ask their level of mobility or activity, or is the pain level affecting their activity? I want to know what type of support surface are they utilizing. Are they sitting on a chair? Are they laying in bed a good part of the day? What other DMEs do they have in the home? I'll also talk about their nutrition, their protein intake, their caloric intake, their fluid intake, or even their labs. You know, what is their pre-albumin level? What is their CBC? Has it been checked recently? And then I'll also bring in our interdisciplinary participation, our occupational therapist, our physical therapist, and of course our nutritionist. So I'm not just like Brenda had already said, we're not just looking at the wound of a patient, we're looking at the entire picture of the patient. What type of living arrangements is the patient living in? What else can I tell you about our program? What we like about the SBAR is that it's clear, concise communication between the staff nurse and between the wound certified nurse, but also between the interdisciplinary participants and also the physician. It gives a very concise communication to the physician. They understand what the nurse is saying. We also have standardized wound care recommendations. It's a basic guideline for the nurses to utilize in the home setting as far as when they call the physician to make a recommendation for wound care. It gives them a nice baseline. What else can I tell you about? As far as prevention, a big piece that I'm working with is our discharge planners at the hospital. So we already want to have a good wound care order in place even before the patient comes home from the hospital. Because a lot of the time when someone comes home from the hospital, you see, let's say, a wet to dry dressing order. We try to contact the physician in advance, the discharge planner, and make a recommendation based on an evidence-based wound care. As far as training with our staff, I have quarterly in-services with our staff at their staff meetings as far as pressure injury, prevention. Sometimes I'll have vendors come in and talk about support surfaces, negative pressure, wound therapy. We have annual competencies where, like Brenda, we also have hands-on tables where the nurses have to show us correct wound measurement procedures, negative pressure, wound therapy application, and also identifying wounds properly. We also talk about our formulary. I do have a standardized formulary in place as far as wound care products. We do have an algorithm in place as far as when would the nurses when would the staff nurses refer out to the wound nurses. We have an algorithm set up so if they don't see an improvement of a wound in 2 weeks, or if they see a deterioration of a wound between visits, if they have a complicated wound, that's our algorithm set up for when the staff nurses should be contacting the wound care nurses. Sometimes the WOC nurse will, or the wound care certified nurse will even, during chart audit, see something or read something, and then they will contact the staff nurse and generate a consult that way. So that's just a quick snapshot of our wound care program at the VNAA Health Group.
Great. Lynn, thank you so much for sharing that with me. And when we talked initially, I thought one of the most interesting things in the program was the way you were really training your clinicians to be proactive in talking with physicians about skin injury prevention and treatment. So the SBAR communications, it sounds like your operative word there was the recommendation at the end. It's not just, oh, I've seen this problem, but using your evidence and the knowledge of your license to recommend a strategy that's evidence-based and patient-centered. So I thought it was really interesting that you recommend that sort of throughout your agency as your way of interfacing with physician colleagues.
I try to standardize the tools so that the nurses feel empowered and confident in contacting the physicians.
And that's a really important issue, particularly when there is evidence around the proper wound care, making sure that the patient gets the evidence-based wound care and that physician practitioners understand what's necessary for that particular patient. So we're just about to wrap up here. I'm going to show you where to download the slides for the overall module overview, but I did want to let you know we'll have a few minutes for questions. We're going to try to get them through the chat box, so if you have a question for Brenda, Lynn, myself, or Danielle, use the chat box on the right-hand side of your screen, and it will come to me and come to Heather, and then I can read it to to the other presenters. So as we wrap up, let me just show you where you can download the slides. Here, get that out at the pressure injury training slides, you'll see the 29 slide set. It has a lot of the same slides we showed you this morning, but then it also includes the very specific information around quality improvement, and then drilling down to the pressure injury thing. So what are you trying to do? How do you get it done? And how do you measure what you've done as an element of success? So we welcome any of your comments, suggestions. As Danielle mentioned, we are going to take a look at the new recommendations on the terminology between pressure ulcer and pressure injury. We may be making changes back to the old terminology depending on the direction CMS is going. But in the meantime, if any of you have comments, suggestions, important things that you're doing that you think could be added, please do let us know. And there's a Contact VNAA button here if you have anything you want to add to it. So we don't have any questions so far, but we are certainly encouraging you to send us your messages via chat box, and we'll respond to those questions. I guess I'll kick it off by asking one question from Brenda and Lynn about how do you use OT and PT, and whether they have a direct role. You know, do they call it part of their job description to help patients prevent pressure injuries, or is it de facto, or sort of how do you engage them in this overall issue?
This is Brenda. I'll be happy to jump in on that. One of the things that we do as we're going through Wound Academy is constantly talk about how utilizing those other disciplines can help, and you know, looking at that Braden score, recognizing when that Braden score is showing patients who are at risk, and then showing them, and I think that's one of the reasons we like bringing in our therapists into these classes, because they can add so much. For instance, if we're sitting there talking about a patient that's at risk or who already has pressure ulcers, how can physical therapy help? Who better to explain that than a physical therapist? And then on the flip side of that, I do have a few occupational therapists who get a little squeamish at some of our photos, but it also empowers them to realize, wow, look at what our nurses are dealing with. And I think it gives them, it opens up their eyes as to what they can do to help, and how the clinicians and the nurses need their help. So just having them in the room for our new hires has been eye-opening, but basically we do let them know that if we see pressure ulcer, certainly as a already current diagnosis, and in fact I believe I said that this morning, if I don't see a request for a PT and OT referral, I'm going to be knocking on your door. So I let them know the importance of that, and how it can help. But again, being able to let the therapist say, oh, well, this is how I can help. Because, you know, they'll question, well, how can a physical therapist help a bedbound patient? And the physical therapist jumps right in there, and the occupational therapist, well, here are the ways. So it's always better to get it from the mouth of the people who are going to be doing it, and so that's really helped.
And it sounds like they're really an integral part of the wound or the skin care prevention and treatment team. Lynn, do you have anything to add to that you could share with us?
Right, so I agree with Brenda, and then in the home visit, when I see that somebody is having mobility, decreased mobility, or essentially bedbound or chairbound, I will bring in and request an occupational and or physical therapist to assist with support surfaces, teach range of motion or active range of motion to either the caregiver or to the patient, adaptive devices in the bathroom, or even, you know, a commode is good, just somebody come out of the bed so that they're not laying in bed. That would be more mobility for them. So that's when I would request for occupational or physical therapy.
Okay, great. Thank you. There was a question that came in for you, Lynn, about could you clarify the experience of the wound specialist at each agency? Who was the first line of consult for the clinicians?
Okay, so because we cover such a large area of the state of New Jersey, and I am the only WOC nurse for the agency, we do have other wound care certified nurses at the branch level. They're going to be, well, our first line of defense, of course, let me backtrack, is the staff nurses with their education that we provide quarterly at orientation. And actually throughout the year, even when I do joint visits with the nurses, that's additional education. So the first line of defense actually is the staff nurse, and then we have branch level certified wound nurses. And then if there's still additional assistance needed, then they'll contact me. Does that answer your question?
I think it does. And I was wondering if, Brenda, do you want to talk a little bit about sort of your lines of consult, who goes first and that kind of thing?
Yes. Our documentation, our software allows for the clinicians to give an immediate referral to the WOC nurse, and we actually have a decision tree for them. So, for instance, any patient with a stage 3 or a 4, you know, there are certain patients, and typically the more complex patients are referred to the WOC nurse, and then our software puts that into new referrals or reevaluations and sort of times that out for us. And then, of course, at any time, a field clinician can contact us via a clinical note or an email or certainly a phone call. It's not unusual to have a nurse in the home call me when they've run into something perhaps that was unexpected. But our software allows for those types of referrals. You know, we do give credit. You know, our clinicians went to nursing school, and the everyday average incision, you know, of course, typically that's not the kind of patient we get in home care. But for those types of patients, we, you know, with their training and Wound Academy, we anticipate that they'll be able to care for those on their own. And because we do have at any one time about 30,000 patients on service, and typically, you know, there are times that we are not available, then that was one of the reasons that we decided to progress with the WTA program. Currently, we are trying to get at least 2 nurses in every branch into that program, and then in addition, we will be asking that at least 1 clinician on a supervisory level go through that additional training. So then we'll have, you know, some more support that's closer in the field than we are, but we do also, on those difficult, complex patients, we will make a home visit, and as well, the clinician goes with us so that we are doing that direct training or teaching in the home with that clinician.
So you're helping to increase the overall expertise through that route?
Absolutely.
Yeah. Very interesting information. Let me see if we have any other questions. This is kind of the last call. So if anybody has questions, please shoot them in. I did get one more that said, who certifies the branch level wound nurses at the New Jersey agency? If not a WOCN, is it a different certification?
It is. That's an excellent question. It's the WCEI program.
Do you remember what that stands for, Lynn?
I can Google it real fast. I know that they're certified wound care nurses. They're just not. They didn't go through the WOCN. They're not board certified.
So it's an external training program with a certificate?
It is, yes.
Okay. And while you're searching for that, I'll just see if anyone else has any final questions. Lynn or Brenda, would you like to add anything before we close out?
The only thing I would like to say is as I said previously, this has been a wonderful experience partaking in this. Been some really smart people involved in this whole process, and this is such a wonderful resource. And I think previous to this, I don't think I was utilizing this resource as well as I could have or should have prior to this. So I've been very happy to participate in this program on both levels, from being able to contribute, but also to be made more aware of what an excellent resource it is, and to be able to share that with my clinicians.
Thank you, Brenda. It's been a pleasure having you involved. And Lynn, do you have any last thoughts before we sign off?
I just wanted to give the name of the program. It's called Wound Care Education Institute.
And the agency recommends or requests that clinicians in each branch get this certification?
We do have, in most of our branches, a clinician with this type of certification, Wound Care Education Institute.
Great. Thank you so much. Well, Brenda, Danielle, and Lynn, thank you so much for joining us today. I particularly appreciate hearing sort of how things work in the real world. And for those of you on the line, I hope you take the chance to look through the blueprint in general and then this new module. You will find a lot of great information to help you with your quality reporting requirements around 5-star best practices, Impact Act, value-based purchasing. There's just a lot of great content. And we do try to make it simple wherever we can, where there's something downloadable that summarizes it. So there's a ton of information. It's a little overwhelming, but we do try to summarize whenever we can and can help you find those tools if you want. So with that, I think I will close. We appreciate all of you all for being on the call and for listening. And again, many thanks to our workgroup members and the workgroup members who joined us on the call today. So thank you very much.